Actually. So
Okay.
let me ask, okay, the recording has begun. Hello, everyone. Good afternoon. My name is Muhammad Khalil. I'm the director of the Muslim Studies program at Michigan State University. I'd like to welcome you all to this panel on COVID-19 and its impacts on Muslim majority contexts. We have with us three distinguished presenters whom I'll introduce in just a moment. I do want to alert you to the fact that we're using a webinar format. So that means that you'll have an opportunity later on to type in questions in the Q&A. So if you're on a laptop, if you move your cursor around, you should see Q&A at the bottom. If you're on a phone, you may need a smartphone, you may need to look around a little bit, maybe look for the three dots in the corner, and there you may see the Q&A. And so that's where you may type in your questions. And actually feel free to type in the questions at any point during the presentation. This is being recorded and we will get started. So first I want to thank Mary Ferdowsi, our administrative lead, for arranging this webinar. And I want to also thank Naila Ahmed for helping us to advertise on social media. At this time, I'd like to introduce our first speaker. So the order is actually going to be Dr. Rizza Nasiri, Dr. Khalida Zaki, and then Dr. Farha Abbasi. So let's begin with Dr. Rizza Nasiri. Dr. Nassiri is professor of pharmacology and toxicology at Michigan State University and doctor of clinical laboratory sciences at the University of Paris. He is the former associate dean of global health in the MSU College of Medicine and former director of the Institute of International Health at MSU. He is also a former professor of family and community medicine in the MSU College of Medicine. His fields of expertise include global health, infectious diseases, tropical medicine. I think I may have had a typo there, but in any case, Professor Nassiri can correct me. Antibiotic resistance, nosocomial infections, public health, capacity building, clinical pharmacology and clinical investigation. And Professor Nassiri writes weekly commentary about COVID-19. And I've actually seen some of them, very helpful, very informative, and has already published 3 papers on COVID-19 and delivered numerous international webinars on SARS-CoV-2 infection. So he will be the first presenter. Each presenter will have about 15 to 20 minutes. We'll say 20 minutes, and then I'll introduce the next speakers after that. So we begin with Dr. Nassiri.
Dr. Khalil, thank you so much. Let me also thank Mary. Mary, you've been very helpful to all of us. It is apparent that this COVID pandemic affected so many countries all over, and I am in touch with numerous countries by way of collaborations I have, especially with Africa, Caribbean, and Middle East. So this type of devastation is no exception for Islamic states, and we're going to be discussing as long as the time allows me for this webinar. But let us first start with the spirit of Rumi. I think we can learn from Rumi a lot, and in every COVID webinar, I start with quote Rumi. Either it's French, because I'm also a Francophone, I grew up in Paris, or Farsi, I put Farsi, and even with Egypt, I had Rumi, translated in Arabic. Egypt is the country where I think Dr. Khalil ancestors are from, But this is excellent saying, that the whole universe is contained within a single human being, and that is you. So it's about us, here, you is about all of us, all individuals, So to begin with, I would like to go over the outline of this webinar, the disease profile in brief, very brief, because the topic today is not clinical. We're just assessing, the whole situation in Islamic countries, especially public health issues, to my opinion, is very important. And then as an example, I'll go over Yemen and find out what is going on in Yemen concerning SARS-CoV-2 infection. By the way, Dr. Khalil, my fourth publication on COVID is coming soon. So let's go to disease profile. This is probably you have seen, there is an incubation period on average of, 5 days, then typical flu-like symptoms, all right? And then some patients may go, progress further, into critical situation. Again, this is not for today, but I'm trying to send a message here. And the message is that right now, as far as pandemic is concerned, we're confronting with numerous variants, okay? Now, some journals and some presentations, they talk about strain. That's totally false. It's not scientific, okay, to say strain. We really don't have new strain of COVID, SARS-CoV-2. They're all variants. No, in the future, if there's a strain, that's fine, because I am a member of international virology nomenclature. So far, we don't have any strain, but new variants such as B117, and most recently, California variants. We have two California variants, very, transmissible, and very fatal. But as it is, in Islamic countries, okay, there is more severe spread of the virus. And there are several factors in Islamic states. Of course, a couple of Islamic states, let us say, Dubai, Emirates, all those two, they have advanced, healthcare, but not every Islamic state has that kind of, privilege. So there are several factors. For example, obesity is one of them, and then chronic conditions such as chronic kidney disease, type 2 hepatitis, and hypertension. These are the things in most Islamic states we have seen it, and that's the reason is, as a matter of fact, I am well clinically connected with the Mansoura, Egypt, and they keep telling me, their patient progress because of, obesity, hypertension, and diabetes. So again, this was a clinical slide, but there was a message there, I just wanted to get the message across. So when you look at the spectrum of the disease, there are basically two responses. One phase is the viral phase. The other one is the hyperinflammatory phase. Again, without going through detail, it appears in some countries, let us say Yemen, Afghanistan, and Syria, and also the North African countries, Islamic countries, they're experiencing a lot over this aspect, I mean, their population, because of the comorbid condition, they progress very fast, to this side of the COVID, which is the severe aspect and affects, organ failures. Again, this is a whole discussion. This slide itself can be for a couple of hours, But again, there are some risk factors, as I mentioned, and these risk factors, especially in certain Islamic countries, appear to be much more prominent than the other, Muslim countries, For example, one of the ways, to diagnose would be imaging, CT scan. Well, guess what? CT scans in some Islamic countries is really a commodity. Not everybody has access to CT scan, which is quite, helpful in establishing diagnosis, although this is not the only criteria, to establish diagnosis. You can see here the patients first, they have ground glass opacities. They're basically peripheral, Then they have, the consolidations, then the bilateral consolidation. That's where, the patients, they progress toward severe disease. In this category, patients, most likely they're obese, or they have hypertension, or they have other, chronic, diseases. So with this small introduction, let's go to public health. In most Islamic countries, there is a lack of capacity of public health. It could be infrastructure, it could be actually the health insurance issues, or socioeconomic. Dr. Zaki, I'm sure she will address that. Or we don't diagnose the disease timely, let alone vaccination. In many Islamic countries, vaccination, really, they haven't started yet. Or if they started, it's a very slow pace. But most importantly, identification of risk group, risk communities, very important. We have millions of displaced Muslims, refugees, in living in Syria as a result of the war, or Iraq, or Jordan, or West Bank, or Gaza, or Yemen. I'll be talking about Yemen a little bit later, and even Libya and Turkey. Turkey is because of, the Syrian war, So we haven't, identified who is really at risk, on these refugee, camps in these Islamic countries. But there are three issues very important when it comes to public health challenges in Islamic countries. One is the proper usage of masks. I've seen it in some Islamic countries. They're not using face masks properly, okay? The second thing is social distancing, as if, social distancing doesn't exist in many Islamic countries, but also lack of testing. The more testing we do, the better we have the rate of, about transmission. So what are the harmful consequences? Well, Dr. Abbasi will address, the psychological, harms, But one of the most important issue in Islamic countries, when I say Islamic countries, I'm not including Dubai, Saudi Arabia, they're part of Islamic countries. So what I mean is most Islamic unemployment, So COVID pandemic has caused tremendous anxiety and unemployment. There are marginalized groups, they're really economically quite vulnerable, especially in countries like Lebanon. Lebanon is really an economic disaster for now. Syria, Yemen, and Libya. Libya is because of the civil war, and that has really increased the anger, and finally post-traumatic stress disorder. Again, the last speaker will cover, these issues in detail. What I call it the side effects of, COVID-19. So what are really the current gaps? Well, current gaps are quite important because when identify them, we can go about bring solution. There isn't much, policies when it comes to prevention. So that's one of the issues of the most Islamic, countries, and currently we don't have any information. What would be the long-term effect of this pandemic in Islamic countries? But keep in mind, most Islamic countries, when it comes to assessment of health effect, it really ties up with their economic effects, okay? And I personally feel that the Islamic academic institutions in different Islamic countries, they should really take more proactive role in communicating this pandemic with the rest of community. So let us go to Yemen. What you can see, Yemen is situated in the Gulf of Aden and the Red Sea, and then we have the Sea of Oman, and then Indian Ocean right here, and the Persian Gulf. The real name is Persian Gulf. It's not anything else, Persian Gulf, okay? So Yemen, okay, has a double pandemic. What is double pandemic for Yemen? That's a civil war, which is very devastating. It's been many, many years, plus COVID-19, it gets double dose. According to the World Health Organization, About 80% of the population is very poor, they're marginalized, and they really live below poverty line. So this is from Yemen Health Ministry, okay? They say it's a low transmission rate in Yemen. Well, it's easy to say that, okay? But it's not scientific, you know. When you claim such a thing, low transmission rate, that means you have testing, okay? We know that in Yemen, there is no testing at all, okay? And when you make this type of statement, that means you have all these public health preventive measures. So Yemen lacks, for example, there is no reliable data in Yemen about asymptomatic. We don't know what percent of the country, you know, population in Yemen, they are super spreaders. We have no idea, you know. And this is a very good estimate. If you get a chance, please, you know, check it out. According to Johns Hopkins, you know, there's about 27%, you know, they die when they end up, you know, in hospital. We know from our statistics in the United States and the rest of the world, you know, the fatality is about 4 to 5%. Actually, the highest fatality in Europe was in Italy, because I'm also professor, visiting professor in Italy, you know, in Milan, you know, they reported 6%. So you can see, compared to the rest of the world, you know, this is extremely higher, very significant. And there's a reason for that. I'll mention some of the reason. Well, Yemen is an Islamic country. 50% are really marginalized. They're really poor. They need healthcare, you know, and here is the issue. Yemen is experiencing malnutrition, parasitic infection, of course, you know, child and maternal, you know, mortality. Well, let me tell you, you know, as far as malnutrition, parasitic infection is concerned, they really bring down, you know, that immune response. You know, in other words, immune response in these individuals are severely compromised, you know, and plus there are some, you know, public health issues, for example, lack of drinking water, you know, a lot of places in Yemen are crowded. There are inadequate sanitation, so on and so forth. You know, in addition, you know, there is a laboratory lack of, you know, capacity. You know, and there is really no robust program tracing, you know, the contacts. Medications are very scarce. You know, and CT scan, it's probably only in Sana'a, the capital city. You know, they don't have any robust prevention program, you know, and basically when we talk of ICU in Yemen, I don't want you to compare the ICU, let us say, you know, with our hospitals, you know, at all. You know, the ICU on classical definition based on WHO definition really is non-existent, you know, in Yemen, you know. Well, there are certain cities, okay, they have limited capacity. Let me repeat, limited capacity on PCR. That's the test for diagnosis of, you know, COVID, you know, let alone, you know, there is no sequence capabilities or capacities in Yemen. Usually they send out some. I should really give credit to the government, two governments, you know, Germany and Dutch, you know, they're being very helpful to Yemenis, especially in case of PCR testing and also sequencing, you know, and especially sequencing is very important because without sequencing, you don't know what kind of variant is there, you know, in Yemen. So Yemen has, well, here is Aden, Hadramaut, and Taiz. They have the highest percentage of transmission in Yemen. So you can see here is a local taxi, okay? You can see nobody is wearing mask at all. Well, the capital city is an exception. And there is a little bit of more public health infrastructure, you know, in capital city. Since 2 months ago, the WHO is providing, you know, population with face mask. But again, you know, proper usage of face mask is very important. So let's say if we compare Yemen to Dubai, okay, there is a world apart, okay. Dubai, highly infrastructured, you know, they have even hospitals with negative air pressure. In other words, dollar talks. Whereas Yemen, they're adding more, to their graveside, because when the people end up, in hospital, basically there is no medication, there is no therapeutic regimen other than pure oxygen. But Dr. Abbasi can identify with me, sometimes pure oxygen could be fire on top of fire, especially when you have, pathologies, associated with lungs. Well, eventually one publication came from Yemen. I'm so happy to see that, because this adds up what I told, so far. This publication says that, the assessment after 2 months, the highlight of this publication was mortality is very high. And keep in mind, mortality in Yemen is below 60 years old. Okay. So in other words, it's a combination of young and elderly. They're dying from the disease, and I personally think most of these fatalities is due to immune compromised state in the population, especially they don't have proper, nutrition. So when it comes to proper nutrition, here is a very recent publication in a prestigious journal, okay, of frontline nutrition. You can see Yemen is one of those countries, has a high rate of, iron deficiency and vitamin A deficiency. These two are very critical in a good immune response, But this is very unfortunate, All of these countries you see right here beside Yemen, they are Muslim countries, okay? Mauritania and Chad and other Islamic countries. So we're not doing well when it comes to nutrition in Islamic countries. So in summary, those Islamic countries with low and middle income, they're facing tremendous, challenges in COVID. Vaccination is another challenge. Until vaccination is not implemented, I personally believe public health measures should be in place. But again, universities in each Islamic countries, they need to take proactive role in public health measures, because the government, they don't have infrastructure for this kind of capacity. I did not talk about therapeutic options, the low-cost therapeutic option. However, during question and answer period, I'll be more than happy to name a couple of therapeutic options for Islamic countries that are in low and middle income, condition. Thank you so much, and I think Dr. Zaki can take over.
Thank you so much, Dr. Nasiri, for a very informative and sobering presentation. As I mentioned earlier, we will save the question and answer session for the end, but please feel free to type in your questions at any time in the Q&A. And now we will turn to our second presenter, and that is Dr. Khalida Zaki. Dr. Zaki is Professor Emerita in the Department of Sociology at Michigan State University. Dr. Zaki received her PhD in Sociology from Michigan State University, MA in Sociology from the University of Baltimore, and MA in Economics and BA with honors from the University of Punjab in Lahore. Before moving to the United States, she was a research demographer at the Pakistan Institute of Development Economics in Islamabad. And she has a distinguished 23-year career in the Department of Sociology and Center for Integrative Studies at MSU, where she has also held adjunct faculty positions in the Institute of International Health, Asian Studies, Muslim Studies, and the Global Gender Centers. Dr. Zaki specialized in social demography and rural sociology with emphasis on South Asia. Her research, teaching, and community outreach has focused on Islam and gender, population studies, women's status and family planning, education and health, Muslim immigrants, Pakistani Americans, youth, and schools. Dr. Zaki continues to build bridges between Pakistan and the US by addressing the development challenges of the education of women, youth, and rural poor in Pakistan. And I'm delighted to introduce Dr. Khalida Zaki.
Thank you so much. How do I share my screen? Because I had it all set up and Dr. Nasiri's presentation kicked it off the screen.
So if you move the cursor around, you should see the share screen option, and don't click. Make sure not to click on the little arrow. Click on the actual share screen option there at the bottom. And when you do that, you'll see a bunch of things that you could share from your own computer.
Share screen.
Yeah. So do you see the share screen option at the bottom?
Yes. So I click the arrow here.
Not the arrow, but just click on the actual big button, share screen, because the arrow is something else.
Okay, share screen.
Yes. And now you should be able to see the PowerPoint as one of the options. So I see PowerPoint here, but I can say share. Yeah, so you will want to double click. Yep, perfect. I think it's beginning to load. Okay, yes, now we see your like your screen. So yeah, I think if you want to enlarge the, yep, perfect.
Am I all set now?
Yes, yep. Yeah, if you want to make it larger, there's the view option that you could select, but we can see the PowerPoint.
Okay.
Perfect. Yep.
Thank you for your patience. I apologize for this time. It's an excellent idea that the group came up with to have this discussion and presentations. And in the context of a global pandemic, I chose to do the Muslim community's responses and Pakistan. So the pandemic came. The COVID-19 outbreak has posed tremendous challenges for families, communities, schools, educators, policymakers. So there we go. What do we do? How do women, families, communities navigate through the challenges and develop the coping strategies? That's how I am going to go. So this is an announcement, the first announcement in the newspapers that came in Pakistan daily, and then the rules were defined. The rules for challenges and opportunities are lockdown. What does it mean? Stay home, social physical distances, personal protection, masks, sanitization. So with that, all the public activity came home. Schools closed and businesses closed. Now the life will not be normal for an uncertain time. Okay, in Pakistan, when we say that, oh, we are all in this together, globally. Yes, we all are impacted by the COVID-19, but how do we respond? So I will focus on some similarities and then some dissimilarities. So the awareness campaign begins. So men and women all prepared to take the charge on. So Muslim global context. The context is global, as it's clear from the previous presentations by Dr. Nassiri, and social, economic, health impact, and then international part I thought include travels a lot. There were a lot of complications. And then I will focus when everything from public goes to the private, that is home, what is the burden on women? Okay. Pakistan was a little late in this announcement, but they take a pretty good, tough decisions with the total lockdown. And this is a railway station. their temperatures are being checked before people board the trains, and so did they do on the airports and other places. So Pakistan is in it, and we are all in it. Now, for the Muslims in general, that is global, for whether we are American Muslims or we are somewhere else in another Islamic country. So I chose to focus on the more common practices: religious, charity, and virtual connections. Those gave us to be on the same platform to address the COVID-19 impact. What is common is religious services, social gatherings, collective meetings, collective activities, public, congregational, Friday prayers, Ramadan, Hajj pilgrimage to Saudi Arabia, Eid celebrations, weddings, masjid, places of worships, Sunday schools, Islamic schools in North America, all everywhere were suddenly shut. That's a big emotional and spiritual impact on the Muslim community. The next is charity. Muslim community, wherever they are, rich or poor, in their own means, they get involved in charitable activities. So since the communities lost the public access, and there are all people who can afford everything and people who are in the middle and in some low income categories, so there was big campaign to reach out. So that provided a unity, food drives, reaching out to the neighborhoods, and neighborhoods became communities. So American Muslims contributed a lot to the relief activities, and with the masks and with the food drives and distributions and taking care of the elderlies and so on. Virtual connections became the choice of everything went online, Zooms, women's circles, and religious practices. So I will not go into details of each of those, but I will be happy to answer questions from our own experiences and from what the world saw about Muslims during the Ramadan, during the Eid celebrations, during the weddings, during the funerals. It was all globally displayed on some sort of media. So it was practiced with distances in North America, and it was practiced with distances in Pakistan or elsewhere or in Yemen, but the difference is in practices. So let's see. That's one scene from a Pakistani masjid, and this is the kind of distances people practiced in the masjids. Okay, so I want to focus now mainly on what does it mean for women in Pakistan. The societal structure of Pakistan is very divided into rural, urban. There is gender role differences, and there is socioeconomic class differences. That's how all societies are structured: race, ethnicity, minority communities, rich and poor. And women are located in all of those classifications. So how does it impact women? So the disproportionate inequality already prevails in Pakistan and in other similar societies. Illiteracy is prevalent, and quality of healthcare is very low. Overall literacy for women, for the male and female differences, overall for ages 10 and above is 58% of the population. 70% of men are in some sort of formal schooling, compared to 49% of the women. Okay, so there is a global understanding and global connection, the announcement came from Amina Mohammed, from the Secretary General of the United Nations, that when women and girls are locked down in their homes, they are at much greater risk than ever before. So we have to now look at that, think about this. So Pakistani women's burden and health crisis began, as I mentioned earlier, that the male dominance in public sphere and female, by dominance, I mean that the gender roles are more defined in terms of the household and domestic activities, child caring, family caring. So what happened then is that with this lockdown, frontline healthcare workers, mostly are women at the lower scale, and that we ignore sometimes. Women are service providers as nurses, as other receptions and taking care of the patients, and doctors and scientists in the medical field. But majority are in the middle ranks or lower ranks. So it has been ignored that women as frontline workers in many countries. Women comprise a majority and they take most of the burden to this work, and by doing so, they are exposed to the risk of contracting the infection. Depends where they are working outside the home, wherever, whatever we call the essential work, women are involved. So their occupations are such that they were exposed. In times of crisis, response task force are dominated by men who make crucial decisions around the outbreak, resulting in the needs of women being largely on sidelines. These results in resources, for example, reproductive health and sexual health resources, which are essential services. All resources from child health, nutrition, they were diverted to the emergency response to COVID-related cases, and all hospitals and clinics and healthcare facilities were as if everything is COVID. So the rest were neglected, and mostly women and children were neglected. The closure of certain businesses, for example, lack of access for women, the closure of businesses disproportionately affected women in professions which they have traditionally dominated, such as they are flight attendants, they are sales assistants, hairdressers, for example. Jobs of domestic workers and others in the informal sectors remain in the precarious situation. As the most are laid off after the pandemic or after going on leave for 6 months with stay-home orders, they work from home for some time. Some jobs cannot be performed from home, like as the services sector and domestic workers in other people's houses and in restaurants. So the closures meant that it's a loss of job for them after some time. The closure of schools and workplaces added additional responsibilities to women when they were staying home. So the closure of schools, what did it mean for women? Children are schooled at home. Teenagers, adolescent children, sons and daughters are at homes. Husbands are at home. Elderly are at home without any outside outlets, outside help, and even the helpers not allowed inside the house. So that creates a lot of pressure for women. They lost the help of their relatives, their neighbors. So what do women do? This is difficult time. So the pressures on all family members in the household is building. And what is the result of that pressure? Who becomes the victim? Who becomes the easy target to throw the tantrums on? That is the woman of the house, the wife, the mother, she's a childcare provider to her elderly in-laws or her own parents. So it's the family context which is affecting them over there. So the rise in domestic violence is of considerable magnitude in sexual violence, honor-based. There's all forms of violence against women increase. And the home is always considered the safe place. But in these situations, at home, young girls, young daughters, helpers of their mothers and others, male members in the house, they had to tend to their needs and foods and around the kitchen. So they were the mostly affected, and it has been on the rise without the support of the outside help. So social contact, when social contact is lost, when physical mobility is limited, that leads to a great deal of mental health and psychological problems. So this has impeded women's coping strategies, and they are suffering from the trauma and without having access to the outside world. So how I am doing on time?
Oh, you're doing fine. It's now been 15 minutes, so you're fine.
Okay. Okay, I'll take a few more minutes. So life-saving care in developing countries has been lacking, and the social support and services are harder to access. And because all those places are preoccupied with the COVID-19 cases. So women's safety is largely at risk in those places. So finally, the services for women need to be provided. The governments need to develop the programs to sensitize the male communities in professional settings and through education. Men and influential leaders need to protect on women's rights during the pandemic and safeguard the respect, honor, dignity of the women and girls. So the government relief programs must include all of those for women of minorities. Rural areas in Pakistan have lack of access to healthcare. So there are a lot of issues. And these issues are not only happening in Pakistan. For example, when I mention the rise in domestic violence, data are not available, and they need to collect the data. And the increase is not only in Pakistan. The data from around the world demonstrated the similar presence as a result of pandemic, whether there is COVID-19 or in spite of COVID-19, but COVID-19 gave it a further increase. So domestic violence against women in China, for example, increased 300%. In UK, it doubled the average of last 10 years. In Lebanon, 43% increase. In India, neighbor of Pakistan, 21% increase. So there is a lot that can be done, and that needs the access. So I would try to stop here, and then we'll take up some more time towards the end if it's available to talk about that the lack of access to technology, computers, internets, children's educations, women's educations, and those who are providing the child care and helping them with their online schooling, they have a lot of challenges and difficulties. So the final point here is the gender equality and women's rights are essential for getting through this pandemic together, to recovering faster, and to building a better future for everyone. And then the UN Secretary General urged governments to put women's safety first and as they respond to pandemics. So now Pakistan is preparing for vaccinations, and it's everywhere. And I stop here. Thank you so much.
Thank you so much, Dr. Zaki, for another informative and sobering presentation. And now, as I mentioned before, we will save the questions for the end. But feel free to type in your question at any time in the Q&A. And now we will turn to the third and final speaker, but as we say, last but certainly not least, is Dr. Farha Abbasi. Dr. Abbasi is assistant professor in the Department of Psychiatry at Michigan State University and core faculty member of the Muslim Studies program, as are Dr. Zaki and Dr. Nassiri. Her areas of interest are cultural psychiatry and teaching medical students how to provide culturally appropriate care to Muslim patients. She works directly with Muslim Americans to encourage integration rather than isolation from mainstream society. In addition to her efforts to build bridges between the two cultures, Dr. Abbasi works as a psychiatrist, and this work has led her to address the barriers that stigmatize and silence mental health. She is the founding director of the annual Muslim Mental Health Conference, which actually they just had their conference about 10 days ago, as well as the Global Muslim Mental Health Conference, which is coming up. She's also the managing editor of the Journal of Muslim Mental Health and director of the Muslim Mental Health Consortium at Michigan State University. She has served on many boards and committees, including Council on Minority Mental Health and Health Disparities with the American Psychiatric Association, and she currently chairs the Mental Health Task Force for the Mayor of Lansing. And with that, I will turn it over to Dr. Abbasi.
Thank you so much. It's an honor to be with my senior colleagues and mentors, Dr. Nassiri and Dr. Zaki. I usually try, and I always am hoping to give an optimistic picture. But as we know that when it comes to mental health, and especially in Muslim majority countries, as I'm realizing, as I'm starting to work there, I can summarize it best that mental health really, it's a riddle wrapped in a mystery inside an enigma. And this is something we see that wherever there is gonna be so much stigma and shame around mental illnesses and health, that's where we see the worst outcomes, the worst consequences. So when I was thinking about doing this presentation, let me first share my presentation. So when I was thinking of how to approach and give everyone an idea of what does this work entails, I realized that instead of talking about individual countries, what we realize is that the same story and the same health disparities and the same struggles are replicated in all of these countries, which is like high need for mental health and limited resources. And when I was going through like what country to focus on, and I realized that Egypt would be a good case study. And it's based on one of the research that I found, not only because one of my favorite Muslims at the campus is from Egypt, and we have all grown up thinking of Egypt as with romanticism and Cleopatra, pharaohs, and, so much history there. But right now, I think with the new political reality, with the Arab Springs, I thought it would be a very interesting case study to follow Egypt, and maybe we can understand how nuanced it is to provide mental health care, especially since COVID-19. So this is a quote I found in the case studies that I was looking at for Egypt. Something shameful to be hidden away. And that's where the stigma breeds, right? Silence, shame, and that's how it leads to stigma. So we know Muslim majority countries are going through so we know that Muslim majority countries are going through political chaos, civil conflict, economic crisis, and that overlapping with COVID-19 now is a continuous traumatic stress. But when we talk of trauma and mental health, we have to understand it like in a biopsychosocial model. Mental illnesses don't exist in vacuum. Yes, you can have genetic vulnerability, but the environmental triggers are also very important and has to be taken in consideration. So we have to understand how this national collective traumatic factors are adding to the burden of COVID-19 stresses that is an individual is bearing. So already they were suffering, they were facing these hardships like we saw in Yemen or in other countries. So we now know major conflicts in the world right now are in Muslim majority countries or impacting Muslims one way or the other, making them one of the really vulnerable population, even if we consider the refugee population or those being displaced or those being killed in war of terrorism on hands of these terrorists, most are Muslim. So given this collective trauma, how COVID-19 is adding to it. So with COVID-19, of course, one thing which is really hard to anticipate or to comprehend or to even have a policy, like a comprehensive policy dealing with it, is that it's like constantly an acute insult happening, and then there is a chronic journey happening. So, and then we don't know when it's gonna end. So we don't have an end date. Usually what we see is when trauma happens, triggers happen, you face the trauma, you have a period of traumatic experiences, and then there's the healing starts. And that's the usual PTSD kind of picture we are talking about. But what is going on right now is acute over chronic over acute again. And basically, of course, there's constant threat, fear of contracting the virus, losing loved ones to the virus, economic loss, or our lives are disrupted. We don't have predictability anymore, and we are socially isolated. All these are very high risk factors. One thing when we think of COVID-19 in global perspective is that population density. So it's not only big populations or big countries, it's where the people are living very closely, where the density is high. That's where is the highest spot for COVID-19 vulnerability. So that's why we saw so many deaths in China, or what we are seeing in India or Yemen, or other vulnerable settings like prisons or incarcerated population or refugee population living in camps. So that's one thing that really is a big risk factor. And of course, like Dr. Nassiri said, economic income level and age group. So interestingly, in my findings on Egypt, another thing that came out was that it actually is impacting people younger than 60 more. So that's a phenomena too. We studied that. Why is it different in those countries? Like Dr. Zaki said, another piece that came out was the gender vulnerability. But another interesting piece is the religious minority vulnerability. So I will talk about it too further. So the social scientists are calling this like a type 3 trauma. So type 1 is when you have acute insult. Type 2 is when you have chronic persistent trauma, but this is type 3 where both are happening. So what happens when someone is suffering from that? It's an individual experiences multiple pervasive violent events beginning at an early age and continuing over a long period of time. Diagnostic criteria, it can impact your memory, consciousness. You can have dissociation episodes, emotional numbing, major developmental deficits, fragmented sense of self, a core belief that he or she is fatally flawed, no will to live or no right to live, so sense of hopelessness, shame, trust. It can impact your relationships, it can impact your academics, and you don't have a sense of future. And this is why the global mental health work in Muslim majority countries is a really tough to do, is that people are living in this constant, toxic, persistent, traumatic states. And the work of healing is not being done because on one hand, you have the ongoing trauma, then you have the stigma and shame. Then the third thing is limited resources. So how do you really bring this together? Of course, the disclaimer, we can't say, talk about it enough, is that still people take Arab countries as synonymous to Muslim countries. But that's why I'm specifically talking about Arab countries where there is Muslim majorities. But that doesn't mean that those Arab countries don't have Christian population or Baha'i population or other minority religious populations. But this was a questionnaire that really I thought was interesting. So they were trying to differentiate between the traumatic stress caused by COVID-19 versus PTSD versus depression, anxiety, and cumulative stress and traumas, right? So Egypt had 255 people participating, and the biggest population that participated, I think, is Kuwait, 442. But what stands out is that Egypt's scores were significantly higher than all Arab countries in COVID-19 traumatic stress. So the stress of COVID-19, also PTSD, anxiety, and depression. And that's why I thought I would focus on Egypt and try and analyze why that's the case. So the result found that Egyptians had a higher probability of PTSD, almost 49%, and higher scores on COVID-19 traumatic stress. And now they will differentiate it. So these PTSD ratings are still higher than when they were studied previously. So what we see is that the PTSD rates in Egypt were higher. They were 32.2%, but now it's 49%. So we can say that the augmentative impact of COVID-19. So COVID-19 traumatic stress is enhancing their PTSD scores. And that definitely then means that their depression scores are higher, anxiety is higher. But interestingly, depression is higher in men and anxiety is higher in women. And depression is higher in the Christian minority population of Egypt. So the religious minority perspective is there as well. So why, if we analyze, Egypt has the highest population density compared to Saudi Arabia, Algeria. And Egypt is also economically really impacted. Why? Because it relies on tourism, 15% of GDP, and is also reliant on oil. So we know that tourism got impacted, manufacturing got impacted. We know Suez Canal, the traffic was impacted, and oil and gas extractive continues to be severely impacted. So all this is creating a slum. And this is kind of increasing the domestic stress levels. So let's go in the history and kind of, I will summarize it very fast, is the trauma, the historical trauma, the collective trauma that Egypt has suffered over a period of, like over the history. So not going in the history where Alexander the Great invades Egypt and all that, starting from modern Republic of Egypt was founded in 1953. That's when the British left, and finally the Egyptians, native Egyptians, got hold of the country. So we know that in recent Egyptian history, the authoritarian rule of Hosni Mubarak, then we know of the Arab Spring and how everybody was focused on Tahrir Square, and the revolution of 2011. But what we saw, the violent clashes, right, between security forces and protesters. And I don't know if these numbers are truly reflective, because that's another piece that we always have to consider about these countries, that how much is truly being reported. But almost 6,000 injured. So then they get rid of that. Mohamed Morsi takes over. And then people get disenchanted by Mohamed Morsi. There's a coup d'etat again, military general takes over again, and General Abdel Fattah al-Sisi now is the president and gets elected in 2014. But that civil conflict, who's with Morsi, who's still following Hosni Mubarak, the civilian and army clashes, all that has created this environment of mistrust, violence, conflict, and trauma, and is impacting the mental health. So Egypt of today is a complex social and political entity, and one that faces a struggle against poverty, population growth, widespread youth unemployment. Another interesting piece is water shortage. We all know that future wars of the world would be around water resources, right? So we are already seeing that happening in Egypt. And threats to food security due to the climate change, due to the pollution in the environment, and ongoing authoritarian regime. So those are the big block in equitable human development, creating equity. And when there is not equity, when there's no social justice, what is impacted is your mental health gets mostly impacted. So a combination of these domestic challenges with instability, continuing instability in the neighborhood, Middle East, North Africa. So Egypt is interestingly is Africa, but gets impacted by all the politics of the region. We also know that the present government, there's a lot of human rights abuse that's being reported, and people have been incarcerated. Even if you don't agree with the policy of the government on COVID-19, people have been put in jail. And then in these incarcerated situations are so bad that many people have died during these incarcerations. So, and the stigma, the shame, how does it impact the mental health? It's underreported. It's not being researched. We don't have exact data, what is going on, and it's underfunded. In a country where I heard that the president is building a whole city now, which is he's spending billions of dollars on, and a very limited amount is going towards health sector. And even in health sector, there is so much need there, like Dr. Nassiri said, the obesity and all chronic health issues, that it's not even trickling down much to the mental health. And then the cultural stigma, right? Some people think mental disorders are punishment from God, or again, the jinn possession or evil eye concept. That's all impacting the care. But what we see, the prevalence is very similar to what we see in America. 25%, roughly 1 in 4 is suffering from some kind of mental health issue. And it's one of the what I should say, remedial impact of colonialism directly impacted the mental health, because when the British left, all of these countries which were colonized had these huge mental health asylums built, right? But the idea was to institutionalize people. And then when they left, these institutes were being used to chain people. So now that the more awareness is coming, a lot of countries are moving away from that model, but there is no community-based model present in Egypt right now. So unfortunately, although Mental Health Act was passed, which talks about patient rights, but what we see is the conundrum is that still most of the patients that are hospitalized are involuntary. And not many are willingly accessing care. And if they do want to access care, they would go to faith leaders first and then maybe go to a primary care setting. So it's only in dire consequences that a mental health intervention will happen. Ministry of Health controls most of the system. And this is more detailed. You can look at the slides, but I just want to give you a bit of, so roughly over, for a population over 75 million. And mind you, Egypt also has another vulnerable population, which is refugee population. So almost 256,000 refugees are settled there, which are registered and unregistered. And so those numbers are also adding to this problem here. So over 75 million and roughly 6,000 beds. So it's almost one bed per 12,000 population. And a healthy recommendation is 5 to 8 beds per 10,000. So you can see how bad the situation is. The numbers, I couldn't find new numbers that how many psychiatrists are there, but we can, even if we say there are, let's say 3,000 maybe psychiatrists now, then also it is an average ratio of 1.6 psychiatrists per 100,000 people in Egypt, which is very disproportionate. And another way the stigma impacts, and that's something I'm really working on through Michigan State University, is that the stigma trickles down. Then the medical students who even want to become psychiatrists are deterred, are discouraged by their families. So that's what we see is only 5% medical graduates are going into psychiatry. And as anticipated with COVID-19, so COVID-19, not only the impact of the pandemic, but what we know is that if you have suffered from COVID-19, it causes inflammation and can directly cause depression and other consequences. So we know that depression has increased, anxiety is increased, substance use disorders are increased. So interestingly, this research found that the OCD increased more in females. So it just, I was thinking Dr. Zaki's presentation, that if a woman is sitting home with all this mental burdens on her, taking care of kids, and it's her responsibility to keep everybody healthy, clean. So if you already have a tendency for OCD, that we did see becomes worsened. You are so focused on germs and cleaning that instead of this intensification of anxiety being helpful, it becomes paralyzing. And male patients are seeking substance use treatment more, but again, that doesn't mean that the women are not using it. A study from Dearborn just came out here in America that more women, Arab women, are using opiates than men. So it's always, I feel like when there is this gender vulnerability, that this is a hidden epidemic that we are not dealing with. So it doesn't mean if male are accessing care that women are not using it. Suicide is another issue. I recently had to do a training with the Indonesia, government of Indonesia. We had almost 100 imams attend, and it was through University of Malang. And their reason being that the suicide rates have gone so high there that imams are now seeking help, like how do we combat this? How can we deal with this? And unfortunately, we cannot access the impact right now that it might be having in Egypt because it's not reported. Egyptian students are under pressure. Of course, having loved what we are seeing here at Michigan State, right? Same thing, that having directly getting infected or having a loved one being impacted, the financial burden, the disruption of academic journey, and then the women are more vulnerable, like Dr. Zaki mentioned, all the causes. So being a medical student in itself increases your depression because you either might be working in hospital settings or know the impact and how it's impacting everyone. Then people who are watching news more can get more impacted. So pretty much same picture what we are seeing. But when we put it in a scenario of where there is already so much communal trauma happening around you, then this added burden could be the last straw. So that's where the urgency is. That's where all the struggle is coming from. And of course, this is the hard situation that COVID-19 infections are increasing. If you go to CDC website, there's a warning now that you shouldn't be traveling to Egypt. It's a level 4 now. So this was on June. So it's like the cases have increased a lot recently. But again, I feel the numbers are underreported. It says only 12,445 coronavirus related deaths. So I don't know if those numbers are really reflective. This is the research, link to the research. With that, I will stop there, and I wish I could give you guys more solutions, like how best to deal with this situation. Few things that WHO is trying, has been trying in these countries is to integrate mental health with primary care. So that's one option. We are hoping that same model can be applied actually here in States, because I wish I could say that we were in a better position here in United States of America, but that's Michigan itself has 33 counties right now without a psychiatrist. So there is a projected shortage even in this country. So I think the WHO model of integrating mental health services in primary care setting is the model to go to. And with that, I'll end there.
Thank you so much, Dr. Abbasi. And I find myself having to use the same two words, informative and sobering. Thank you for that presentation. Now it is time for the Q&A. And so please feel free to type in your questions in the Q&A. And we already have two questions. The first one is from Sydney June. Actually, both are from Sydney June. And the question is for first one is for Dr. Abbasi. Would you say the mental health issues due to COVID-19 will make it harder to get back to a normal routine or integrate back into society once things go back to normal? Also, do you think there will be long-term effects to these mental health issues? So Dr. Abbasi?
Yes, unfortunately, yes, because we don't know. Again, it's an ongoing pandemic, right? So like I said, the trauma 3, that acute over chronic and chronic, then more acute incidences are happening. But it's not only in these countries where there is already civil unrest, there's poverty, there's population growth happening, then the refugee situation. I don't see any break there anyhow. On top of that, this COVID-19 is directly impacting all these factors. The refugee population would get impacted further, economics would get impacted further, the pollution will get affected, the environment. So everything is getting disrupted, right? So there is that indirect impact of COVID-19 that we don't know when it's going to end and when do we start recovering and healing. But then there's a direct impact of COVID-19 on brain. What we are seeing is it is causing some kind of inflammatory process. People who have didn't have any other health issues when they have recovered, they have gone on to develop depression and anxiety. Other thing is substance abuse disorder. The dual diagnoses are increasing, right? The more we are socially isolated, we saw that even in our own country, that the alcohol sales doubled. So the more you are isolated, the more you don't have access to healthy coping skills, the more you will depend on substances. So that's another issue. Other thing is violence, like Dr. Zaki said, in these unhealthy environment, what we saw, the gun sales went up 200%. And we are seeing the outcomes right now. Again, aspect of these gun violence, shootings, homicide, suicide kind of situations happening. So sadly, I feel we are in this for a long haul. But what really breaks my heart is that even in the best developed of countries, the mental health policies are so defective. Like, literally, these are faulty policies stitched together with good intentions. But there is so many cracks everywhere, including our country.
Thank you, Dr. Zaki, Dr. Abbasi. This next question is actually for Dr. Zaki. This is from Sydney June as well. Dr. Zaki, do you think this increased violence against women could also negatively impact children living at home as they are learning by watching their family? If you're looking for the mute, it should be at the bottom left.
There I go. Okay, that's a wonderful question. It's a very important question. Yes, when we say hate breeds hate and violence breeds violence, it doesn't matter under what circumstances and in what type of environment it happens, it affects the people around you. And definitely in the family context, there is documented evidence, whether it's the United States or whether it's a developing country, that whatever the children are being socialized into and they're seeing the harassment and abuse or other type of violence, they are impacted by it. They are afraid, they lose self-esteem, they lose confidence, they develop anxieties, and that lives with them for a long time. Yes.
I would like to quickly add to that too, building on that. We have a saying, hurt man, hurt man. So it's a cycle of violence that goes on from generation to generation. And when we profile, especially these cases where this gun violence happened, these kids usually have been exposed to some kind of violence, domestic violence or other bullying or some kind of violence.
Thank you for that. Now, actually, I'm going to ask my own question to Dr. Nasiri. Dr. Nasiri, I wonder if you could, you did touch on this, but I wonder if you could give us a picture of the vaccine distribution in Muslim majority countries, specifically in Yemen or in general. What kind of vaccines are people, potentially, what are they beginning to have access to? How effective are they, et cetera?
Well, thank you, Dr. Khalid. As you know, in the United States, we have currently 3 vaccines, Pfizer, Moderna, Johnson & Johnson, and of course, Novavax is coming soon. And then we have Chinese vaccines and Russian vaccines, along with AstraZeneca, which is Oxford AstraZeneca, product. Now, with respect to distribution of vaccine in Islamic countries, WHO provides them with vaccination quota. okay? And basically, well, Pfizer has all these restrictions in terms of temperature, so on and so forth. I don't think it's going to be ideal vaccine, let us say, in Syria, Afghanistan, you know, or Yemen or Libya, you know. But certainly other vaccines such as AstraZeneca, you know, and hopefully Johnson and Johnson, you know, will be distributed, you know, along with Russian vaccine. Now, the Chinese vaccine, first of all, it's not approved by the WHO yet, okay? And so that's an issue that needs to be addressed. However, you should keep in mind the World Bank also has distribution, you know, center for, you know, all countries. It's not even Muslim majority countries. And then, you know, there's a COVAX program, which is under the auspice of the WHO. So they're getting vaccines, but they're not adequate, okay? For example, when you hear WHO gave 3 million doses of vaccine, essentially it's 1.5 million, because these are two divided doses, except Johnson & Johnson, you know, I took myself Johnson & Johnson, you know, it's a single dose, okay? Now, this distribution, you know, to Muslim majority countries really should take place as soon as possible, okay? And the reason I'm saying that, you know, actually my next article will be on this issue, not specifically Muslim Islamic countries, but in general, you know, we are now confronting the rapid, I repeat, rapid emergence of variants such as B117, B1135, which is the South African, you know, and most recently, two variants of California variants, you know. So I'm hoping these variants would not reach to some Islamic, you know, states. So otherwise, you know, it would, then, you know, it will really compromise the efficacy of the virus. But also keep in mind, you know, here's an issue, you know, Dr. Abbasi alluded a little bit, you know, on that. We have some Islamic countries, they can really afford to purchase vaccines for other poor Islamic states. I mean, this is no brain at all, okay? That is not happening, you know. Maybe it's happening to some, you know, level, you know. But also the other issue, for example, in Egypt, Dr. Abbasi alluded, you know, it's a corruption. And it's not only Egypt, you know. In Iran, there's a corruption. You know, I'm sorry to say, both the speakers are from Pakistan, you know, but we're culturally related, you know, Pakistan and so many other countries, you know. But also, we should take into consideration the culture of a country. For example, okay, in the past 10 years, the WHO has lost 5 vaccination workers in Afghanistan, because some tribal, you know, attitudes in Afghanistan, they don't like vaccination. They think it's haram, it's against God, okay? And these 5 healthcare workers actually in Afghanistan, in the Taliban country, for your information, were beheaded, okay? That was for other, you know, vaccinations purpose, you know. So to summarize about your question, it should be a concerted effort of Islamic states, and plus, you know, the contribution of those Islamic countries that are rich, they can afford to pay for lower, you know, economics, you know, for other Islamic states. But keep in mind, WHO currently is overwhelmed. You know, I have connections, I consult for WHO. They're overwhelmed with vaccination issues, you know, and we cannot solely rely on WHO or the World Bank, you know, or other agencies, you know. I think this is a Muslim issue, and it should be solved by Muslims. And let us, for the first time in the history, okay, I'm not going back to golden history of Islam. You know, I grew up in Europe. I mean, when I studied, you know, Islamic Spain, you know, it was the golden, you know, age and golden era. But let's now demonstrate one more time, you know, we Muslims ourselves are capable of handling our affairs.
For that, Dr. Nassiri. And this actually raises another question that I would
Yes.
actually pose to all three panelists. And that is, you know, right here in the United States, there is some resistance to the vaccine for various reasons. Dr. Nassiri mentioned in a case in Afghanistan where some people thought it was haram, it was forbidden. And so they had a very violent reaction. When I speak to some relatives in Egypt, I notice some are skeptical. They doubt that the vaccine is actually effective, or that maybe there's something there. I wonder if you could, if each of you could comment on the reactions to the vaccine. Maybe we could go in order of the presentation. So Dr. Nassiri, Dr. Zaki, and Dr. Abbasi. Dr. Nassiri.
Yeah. Well, as I said, you know, that's the cultural, you know, attitude in some, you know, Islamic countries. You know, we need to improve that. I think that the work of Dr. Zaki and Dr. Farha Abbasi, it's important, you know, and that's the social and psychological aspect, you know. But also we have to keep in mind that there is that, well, let's put it this way. I belong to a group discussion, basically Henry Ford Hospital, you know, and Beaumont. So they adopted me as their group. We exchange information, and it's been almost a year, actually. We're a group of 76 clinical professors, you know, and doctors. We exchange information. You wouldn't believe, okay, in that triangle of Detroit, Ann Arbor, where I did my fellowship before, okay, 40 years ago, and Lansing, East Lansing, that triangle, you know, 30% of our physicians, educated in USA, trained in USA, gun residency program in USA, they do not believe in vaccines. Okay, that's shocking statistics, 30%. And they're always calling upon me, no matter what I tell them, okay, on vaccines, they're still reluctant to take vaccine, okay? As you know, right now, we don't have any established law by the Senate of the United States that vaccine is mandatory, okay? Somebody can refuse it. As a matter of fact, you know, I know many people, they cannot take, or they don't take annual flu vaccine, you know, for the religious purpose, you know. And even in the United States, you know, Dr. Abbasi was telling other religions, we have a religious minority here in the United States. They refuse, you know, to take vaccine. So what's the solution? Solution is not in my hands. Okay, solution really is in hands of two individuals that participating today, Dr. Zaki, you know, and Dr. Farha Abbasi, how we can come up, you know, with a robust, you know, social program and psychological program to remove this stigma. Stigma is a really big issue, including in this country, United States. Now, as far as vaccine efficacy, well, there are several, you know, vaccines, they have different efficacy. But let me tell you, all those 90%, 95%, you know, here, essentially from perspective of science really doesn't mean anything, okay? An effective vaccine is a type of vaccine you take, either your immune system adopts it or rejects it, okay? That's why it says 95%. That means among population, there's 5%, even though they receive vaccine, they still develop disease, okay, infection. So assuming, you know, those, you know, take vaccination and it works on their immune system, you know, there's still possibility, you know, they may come up with infection. Actually, I'm personally aware of, 5, 6 cases myself. One of them, a very prominent, cardiologist, in Detroit area, after second vaccination, developed, COVID, PCR positive, and we did the quantitative, spike protein IgG, again, positive, but I don't want to go to detail here, but I can tell you for sure, and that is on CDC website and WHO website, vaccination helps to reduce, transmission. Vaccination helps to reduce the hospital administration, and vaccination helps to reduce, ICU admission.
Thank you, Dr. Nasiri.
Thank you.
It is actually 3:31, but I want to make sure we hear from Dr. Zaki and Dr. Abbasi. So Dr. Zaki, we'll turn to you. Oh, it is muted now, actually.
Okay. I think there are several reasons for people saying no to the vaccine. And Pakistan is getting the Chinese vaccine, whether it's approved by WHO or not. Even the other vaccines which are available in Europe and in the United States, they are also only approved for emergency use too. So, so people mistrust is because of lack of education. That is one reason, lack of education and trust in science, and then mistrust in the leadership, how it's being promoted and how the masses and the communities are being educated about it. So the information is coming in the mixed packages and people do not have trust in them. So there are political motives behind in several situations, different political organizations are advancing their agendas and people don't trust either which way is the right way. So when there is a positive way, the pressure comes from the peer and from your own community, your own leaders. When they're being vaccinated, then the rest of the people build a trust that way. The other limitations people feel is that all these vaccinations have been developed and brought into the world market by the organizations, multinational organization for business purposes, and how the developing countries are going to be impacted by that. And the reason behind for the corporations and pharmaceutical companies is to build, to generate profits for them. That's one of the reason too. For some, it is free. Early on, it's promised for free, but now it has, like for example, in Pakistan, it has been private doctors and clinics are also importing on their own, and they're charging high prices for those vaccinations. So when it's available for free, then majority of those who can't really afford the health care, then the vaccination is so expensive that it will be difficult for them. So it has to be some sort of, those are main reasons.
Yes,
I think.
thank you, Dr. Zaki.
Yeah.
Dr. Abbasi?
I would just add one thing in context to United States of America. We are reaping the impact of structural racism as well, the mistrust in the system. So there is, of course, the ugly reality that laced with political agenda. So we have that group not believing in it and not wanting to be vaccinated. And that's why we are seeing an increase in Michigan right now of the cases. But then the population that I'm talking about is who have the mistrust in the system. After the Tuskegee trial and all the history, the trauma of minorities in the country and the impact of structural racism. So I think one thing we should always remember that COVID-19, everybody says is an age of masking. I say it's an age of unmasking. It has really opened our eyes to what we knew, but now we have to deal with it, is the health disparities.
Yeah, thank you, Dr. Abbasi. Well, we are 5 minutes over, so I want to thank all three presenters, Dr. Rizza Nasiri, Dr. Khalida, Zaki, Dr. Farha Abbasi, for a very interesting presentation. And thank you for also agreeing to have this recorded so that we can share it with others. Thank you, everyone. Have a good rest of your afternoon and evening, and Ramadan Kareem. Thank you.
Thank you.